One is going to talk about MIGS, tips and tricks to minimize intra and post-operative morbidity. Dr. Suneeta Dubey.
Okay, thank you. Good afternoon, everyone. Slides are not moving. Yeah. So, MIGs are used either a surgical device that incises, excises, or ablates the TM, like in GAD, KDB, and trabectome, or as an implant, like in iStent and Hydrus. So, generally, MIGs are performed after the options of medications and lasers are being exploited with or without cataract surgery. However, they can be done even after cutting surgeries. So compared to traditional glaucoma surgeries, MIGS have fewer risks and complications, faster recovery time, they can reduce the medical burden and therefore improve the quality of life. However, they definitely have a steep learning curve. So one should be very well aware of the prerequisites of angle procedure before starting the procedure. And most importantly, one should master the art of gonioscopy, which is a key to successful procedure. And we are used to coaxial illumination while operating cataract surgery or other intraoperative surgery, but in MIGS, one has to get used to the microscope setting and positioning, wherein you have to tilt the microscope 30 degrees towards you and patient's head away from you so as to have an angle of about 70 degrees. So this is very, very important, and you need to choose the open angles, especially during your learning curve, so as to have the en-face view of the angle wherein you see all the angle structures very clearly. And also it is important to review the comorbidities the patient may be having, and patient should be able to follow these commands intraoperatively, like tilting the head or moving the eyes away from the specific direction of gaze. So it's very important to counsel the patient preoperatively. So you can even use this calculator tool, which is available online, which takes into account a lot of prerequisites or the preoperative requirements which you should monitor, and you should document in your file before performing the MIGS procedure. So you can use any of these lenses, gonio, which are the gonio Vogue surgical lenses, eye prism, or disposable lenses. However, take care that you do not compress the cornea. The gonio lens should keep floating over the bed of cohesive viscoelastic over the cornea. And this will avoid corneal folds and improve the visibility, and use high magnification to observe all the structures clearly. As I said, and fast view of the angle. Now, as far as the incision is concerned, when you are combining, even without cataract surgery, you have to give incision, a clear corneal incision, so as to avoid the limbal bleeding. Because if you make the incision at the limbus, you can nick the limbal vessels, which can hamper the visibility of your procedure, because it can just spread over the cornea. A 1.8 millimeter incision is enough uh, to have good maneuverability from side to side, and incision can be flared posteriorly, so you can just enlarge the incision from inside to allow greater excisional range, wherein you can just keep rotating your gonioscope and treat the angle. A Hook dual blade goniotomy is specifically designed to treat the angle, as it has a sharp tip which pierces the TM. The ramp lifts and stretches the TM and feeds it into the dual blade, and the heel of the foot plate nicely settles within the canal. So with this device, there is no collateral damage and it is very safe. So aim for a very precise technique under good visualization, under high magnification. So as you engage the trabecular meshwork, you have to move along one side of the canal, as you can see, and you can nicely see this strip coming off. So be very careful that you are excising the right area, and once you have completed on one side, but just keep moving your gonioscope over the cornea. You just rotate your tip and do it, the procedure, complete the procedure on the other side. So you should see this trabecular strip which should come out during the procedure. of KDB blade or bang. And after that, you can finish off your cataract surgery and then just remove the strips. So you can remove the strip as in this video after completion of procedure with this the help of this micro forceps. So you can just take out the strip nicely. Also, it is important to elicit this episcleral fluid wave. So when you hydrate, you can see blanching of the vessels. So initially when you see there are vessels which are seen filled with blood, but when you inject fluid through your hydroincision, you see this episcleral blanching of vessels, and the success depends on the patency of distal collector channel. So when you combine these procedures with cataract, I usually perform cataract first because uh, the big advantage is that the eye is not hypotenuse and it will not lead to excessive blood in the Schlemm's canal, which can hamper or obscure the view. So I perform the cataract surgery first, as in this particular patient, a patient with trauma, with traumatic cataract, intractable glaucoma. He had this total traumatic cataract with PC rupture. So you can see before doing the cataract surgery, you can visualize the angle properly, make a cleft. The angle was open in this particular patient. And once you have made a nice cleft, then you can continue with your cataract surgery. Although it is not hard and fast, you can even perform cataract surgery first and do the goniectomy later. So this patient had PC rent because he was a traumatic cataract. So the vitrectomy was done, and then 3-piece IOL was implanted in the sulcus. So the patient did well after the procedure, and the nice cleft was seen. As far as GAT is concerned, again, there are certain points which you need to keep in mind, that when you're doing this 2 millimeter goniotomy should be done. The goniotomy should not be very big, otherwise it will be difficult to insert the proline suture. So once you have done the goniotomy, you should use this mushroom-tipped proline suture and advance it in a counterclockwise direction along the circumference of Schlemm's canal, and you should not feel any resistance. Because if you're feeling resistance, then you may be not in the Schlemm's canal. You just pull it on the other side so as to incise the trabecular meshwork 360 degrees. So it's very, very important that you don't feel any resistance. If you are feeling any resistance, you can use your indirect gonioscope to visualize whether the proline suture is in the angle. Last, the eye stent. Again, it is available with the injector. So here again, as I said, you need to have a very good view and fast view of the angle, because you have to actually implant the device into the trabecular meshwork. So you just indent the trabecular meshwork, the anterior part, keep the trocar perpendicular to the TM and gently dimple it. It should not be too much or too little, and this reflux of blood is a good sign that you're close to the aqueous vein, and then just move 2 to 3 millimeter away and implant another device. So it comes with 2 eye stent injects. And then just check the position of the implants intraoperatively only, that they are nicely placed in the trabecular meshwork. So post-operatively, again, depending on the inflammation, you can give the patient steroids 6 to 8 times and then gradually taper them off. Monitor for the elevation of IOP. Sometimes, especially in GAT, you can get hyphema, which will clear on its own within days or weeks. It rarely requires an AC wash. Prolonged inflammation, I think you should have a check, because it can lead to PAS and it can close the cleft. Gonioscopy should be performed frequently to check for cleft patency and formation of PAS. So to summarize, intraoperative gonioscopy is truly a foundation for MIGS, and success starts at clinic with proper patient selection. As I said, you just have that patient selector tool, and you should document each and everything preoperatively so that you don't have any problem intraoperatively. And I would advise that you should practice these procedures in the wet lab to get used to the bimanual conditions, and good visualization and understanding of the angle is the key. To start with, I would advise that you can start with more simpler procedures like bang, and then switch over to the other procedures. Thank you very much.
Thank you, Dr. Suneeta. Thank you so much for giving us insight into the